Dr. Fathiya, welcome again. The floor is yours.
السلام عليكم ورحمة الله وبركاته. مساكم الله بالخير جميعا. Thank you, Dr. Saja, for the kind introduction, and it's really my great honor to be within the group of the nephrologists in Oman. Thank you for this very kind invitation and for attending this out of your evening time. Inshallah, I'll try to be to the point, and we will try together to reach some learning objectives behind the renal involvement in Fabry disease. We will talk about some specific aspects in natural history and management as well. I would really appreciate it if you stop me at any time, ask me at any time, or if you feel the presentation is too long, just I can stop. But inshallah, we wouldn't go over time بإذن ta'ala. This talk received sponsorship by Sanofi. And we will just go over a case presentation of a patient with a classic Fabry disease to just get an idea what kind of patients we are expecting. And through him, we will go to the basics of pathophysiology of this disease and review very short the clinical presentation, diagnosis, and management. The rest of the presentation for the nephrologist will be focused on the chronic kidney disease and Fabry disease. I admit that I'm a bit nervous to talk about kidney disease with your expertise in nephrology, but I'll try to do my best and go through the natural history, the things that we need to know in the management of these patients, your insights. Then after the presentation or during the presentation will be very appreciated. So this was my regular clinic day, and a man came through the door. He did not have an appointment. He was 36 years old. He was single and married and works in gold mining. Actually, the appointment was for his nephew. He was known to have Fabry disease, but this man came to the clinic significantly short of a breath and said, over the past 1 week, I have severe episodes of chest pain. Reviewing his medical history was significant that this patient, since he was a child, he had episodes of severe pain in hands and feet, and that compromised his childhood. He was actually diagnosed with hypertension since his early 20s. He has progressive fatigability and exercise intolerance, and he used to have reduced sweating and heat intolerance as well. On a specific questioning, he didn't come up with that by himself. On examination, he looked miserable. He had significant, obvious bilateral clubbing. He had angiokeratomas. We will see that on his trunk and scrotum. He had bilateral pedal edema, crepitations in his lungs, systolic murmur that was loud. But his neurological exam, at least, was largely unremarkable, apart from generalized hyperreflexia. So I sent this gentleman to the emergency immediately, and the basic investigations showed polycythemia, high WBC count, and he had heavy proteinuria and high BNP of close to 800. Uric acid was elevated, vitamin D was low, and his creatinine was 195, urea was 16.3. And his eGFR was low at 33. He also had high TSH and high T4. So the ECG done showed elevated ST segment from V1 to V3 with reciprocal ST depression at the inferior leads, and the echo showed moderate concentric left ventricular hypertrophy with hyperdynamic systolic function. Ultrasound kidneys showed diffuse increased parenchymal echogenicity of both kidneys, and he was diagnosed to have chronic kidney disease stage 3A with heavy proteinuria, which was considered to be a bad prognostic sign for the progression of his chronic kidney disease. We knew that he has Fabry disease. That didn't need us to think, actually, because of the family history and the textbook presentation. We did his enzyme. He did not have the enzyme. You can see that the enzyme activity is actually so his enzyme activity was 0, was basically non-detectable, and he has a variant in the GLA gene that is actually, we call it truncating variant. So when you see this change in the gene, you know that there is no residual enzyme activity corresponding to classic disease in a male patient. This is our guy, and you can see that it was very easy to spot him. Actually, for 7 or 8 years, I was trying to call him to come to the clinic because we were getting all family members through the family screening. Finally, he came, but at unfortunately very, very late stage of the disease. So just giving you an insight, what did that disease do for this young man in the beginning of his age? We will go through what is really Fabry disease. We will go through the basic pathophysiology of the disease, and then summarize the clinical presentation. So Fabry disease is a problem in breaking down complex lipid molecules called glycosphingolipids. All complex molecules in our body are broken by biochemical reactions through enzymes, and enzymes are encoded by our genes. So if the gene encoding an enzyme is not working, that enzyme will not be produced in the body, and then the biochemical reaction that it is meant to facilitate will not happen. To go more into what are these complex lipids, these are actually glycosphingolipids. And glycosphingolipids are very important molecules in our cells. So this is the cell membrane, and here are glycosphingolipids. They provide the structural support to the cells, but they play really very important roles in regulating the cell differentiation, cell proliferation, and apoptosis of the cells. So they are vital to the function of the tissues. And there are many types of them. This is specific type called globotriacyl ceramide, so or GB3 for short. So this is the sphingolipid molecule called ceramide as well. As the name implies, a sphingolipid means that there is a lipid molecule, a fat molecule, and a molecule called sphingosine. So this is a complex lipid molecule. Adding to its complexity to play its specific function, 3 sugar molecules are added to it. So the name JB3 comes from the name of the 3 sugar molecules attached to this molecule. And when we come to GB3 specifically, we will find that it is located abundantly in the capillary endothelial cells, but also in every cell type in the kidney. In the kidneys, it's present in our podocytes, tubular cells, glomerular endothelial cells, mesangial and interstitial cells. So in the kidneys, this is the only tissue where you have the GL3 in every cell in our kidney. It is also present in our heart, in the cardiomyocytes and fibroblasts, and in the nerve cells. This is the normal, natural presence. But like any other complex molecule, we make it and we break it. So to break it, as we break all complex molecules, we have to break each sugar molecule at a time. We can't just break it in one step. And for each step, as I told you, to break this bond, you need a facilitator, which is an enzyme. The enzyme, in the case of GB3 or a globotriacyl ceramide, is called alpha-galactosidase. And when alpha-galactosidase is missing, we cannot break the first galactose molecule or sugar molecule attached to the GB3. And with time, GB3 will keep accumulating and doubling and doubling and doubling in the cells, where will harm the cell, will lead to the cell stopping its function, and will lead to cell death. And at the tissue level, that will lead to complete loss of the function of the cell. Okay. So when we come to the diagnostic test for men, because this gene coding for this enzyme is located on the X chromosome. Men have 1 X chromosome, and women have 2 X chromosomes. the man who has one X chromosome, if he doesn't have a copy of the gene, he will not have a spare copy to produce the enzyme. So as you saw with the patient I showed you, men with a classic disease will have very low or undetectable enzyme activity, and enzyme activity is the gold standard diagnostic test in affected males. That is number one. Number two, the GB3, if you don't break it down, you can actually measure it, and you can find that the GB3 or its metabolized lyso GB3 is elevated. In males, we typically see very high elevations of lyso GB3 that are diagnostic, but I mean, again, females, the enzyme will be normal, and lyso-Gb3 will be borderline-ish. So the diagnosis based on biochemical investigations, it's rather difficult, and many of the times is non-conclusive. And we have to go for the genetic analysis straightforward in females when we suspect Fabry disease, but we do it with the lyso-Gb3 analysis as well. The gene analysis comes with its challenges, because not all the time you will find variants of known pathogenicity, but that we will leave that to a different discussion. The clinical manifestations, it's a disease of childhood. Everyone thinks that Fabry disease is, just checking the time, everyone thinks that Fabry disease is a disease of adults. No, this is a disease that starts in early childhood. The children can be manifesting even as early as 2 and 3 years of age. There was a case report of a neonatal presentation. But the manifestations will be more clear by the age of 10, and there will be these raised dark skin papules, what we call as angiokeratomas, that are seen over the trunk in the scrotal area in about 60 to 70% of the affected patients. It's more seen in the males, but I have 2 female patients with extensive angiokeratomas as well. And you can see the telangiectasia as well, the dilated capillaries here, and this is one of my patients as well. The main disease manifestation in early years is really the episodes of severe neuropathic pain that could be very disturbing to the life of the patients. And the patient as well will be fatigued, but he wouldn't know that, because the word fatigue is very non-specific, and we all say I'm fatigued, but these patients are more fatigued than any of us, and they have reduced sweating, they have reduced perception to cold and warm objects as well. So as the patient grows, the GL3 deposits in all tissues will increase, and what really matters that their deposition in vital organs like the kidneys, heart, and brain will lead to dysfunction of these organs and catastrophic consequences. Indeed, the life expectancy of Fabry disease patients is reduced by an average of 25 years for men. This is significant, but really what is more significant that the quality of life is really miserably reduced in men and women with Fabry disease. And maybe my patient could give you a light of what I'm talking about. It's not just disease of increased mortality, but also the morbidity related to the other complications of the disease, including the progressive sensory neural hearing loss, the GI dysfunction. The patients are usually full bloated, they are nauseous, they are constipated or having diarrhea, they are never comfortable when they eat, they have high preference of psychiatric manifestations, depression, major depressive episodes. I have one patient with suicidal thoughts, and are very common in the patients, and we need to pay attention to that. Restrictive lung disease and significant osteopenia among some of the complications of this devastating disease. How to solve the problem? We can think about supporting treatment for every organ system involved, but indeed to solve the problem, we need to do something to remove the accumulated sphingolipid. And this is through replacing the enzyme through what we call as enzyme replacement therapy. Is actually indeed the main targeted treatment therapy for Fabry disease, but I should mention that for some genetic changes, there is what we call as chaperone therapy. Chaperones are these small molecules that can bind to the enzyme and improve its activity. Now you can tell that in our patient, the variant, the genetic change caused no enzyme activity to start with. So chaperone therapy does not help in our mutation. Enzyme replacement therapy now is known for like 2 decades for Fabry disease. We have good experience with it, and we know very well its value in slowing the progress of the disease and improving the patient's symptoms and quality of life. Up to here, I finished my review about the disease, and I'll be focusing about the renal manifestations of Fabry disease. This is a nice relatively recent review by the Canadian group, and I would advise people to go through it. The majority of my information actually were based on the information based on this review and some other resources, but this was my main resource here. When I talk about kidneys and Fabry disease, the nightmare for all of us, especially nephrologists, are we missing these patients among our patients with chronic kidney disease and dialysis? And because it's a nightmare question, there were so many people who tried to answer these questions, and there were, alhamdulillah, so many studies done to prove that. So you can, from the different studies, overall, the prevalence and patients who are on dialysis and found or confirmed to be affected with Fabry disease was ranging between 0.2 to 0.9% in males and 0.05 to 0.3% in females. This is I like this study. It's the largest. It included almost 37,000 hemodialysis patients, and they found that 2 patients among 1,000 patients on dialysis were found to have Fabry disease in males, and approximately 1.5 in 1,000 incidents in females. So if you reflect that on Oman, you can think that, okay, we must be missing patients, not so many, but we may be missing patients definitely. Talking about the nephropathy or the renal involvement in Fabry disease, there are some peculiarities about the renal involvement in Fabry disease. The most important information that actually renal disease among different Fabry patients differs remarkably. There are so many factors for that. What was the baseline of the patients, the degree of proteinuria, the baseline GFR, male gender is associated with faster disease progression, but also there are factors outside that. There are factors, the environmental factors that differ between people. There are other co-founding diseases, and there are other genetic modifiers as well. So we wouldn't expect that every Fabry disease patient will have the same natural history in terms of the renal progression of his disease, but there are general highlights that we can make here. There was one study of males with classic Fabry disease, and it identified that the GFR decline was of 12.2 ml per minute per year, with rapid progression to end-stage kidney disease. The prediction and consistency is actually easy with males with a classic disease, because in females and patients with later onset variants where you have a little bit better enzyme activity, the GFR decline cannot be predictable. There will be so many factors that you just cannot have a rule for the GFR decline. For example, some female patients will live throughout their life, they will not have any renal disease, and some female patients will have renal disease, and we do have this in the clinic as early, and we have a female patient who had renal involvement earlier than other untreated men that we have in our cohort. The natural history. Let's take the journey of the renal disease of the patient from the beginning. At the beginning, like in the first 2 decades of life, typically the blood pressure in Fabry patients will be lower than average. And this is because autonomic dysfunction is very common in these patients. Most of them have the neuropathy and autonomic dysfunction. But once the kidney becomes involved, the blood pressure will turn into high blood pressure. The other more common finding in Fabry patients, they have more or higher incidence of renal cysts, and some Fabry patients present or come with hematuria, although this is not really common. After that, the typical natural history is really very similar to diabetic nephropathy, with you guys know very well. There is hyperfiltration at the early stages, and with the common presence of albuminuria, proteinuria, and a progressive decrease in the GFR. So in younger patients, glomerular hyperfiltration is relatively common. And as the disease progresses, endothelial cells, podocytes become more filled with the GB3 molecules. Well, GB3 is lipid, right? So that's why you will see foamy vacuoles in the cells, and the cells will be enlarged, stuck with these molecules, and they will appear large and foamy. At the end, there will be irreversible ischemic changes in the renal microvasculature, will worsen the entire picture and progression, and will result into glomerulosclerosis, thickening of the capillaries wall, a tubular atrophy, interstitial fibrosis, and arterial sclerosis. So for males with classic disease, they go into the need for renal replacement therapy, and they're usually in their 30s or in their 40s of life, unfortunately. Okay. So this is the natural history of the renal involvement. How can we diagnose the renal involvement earlier in Fabry disease? One of the common diagnostic markers we use in the clinic, we use routinely and we depend on, is we frequently check for albuminuria and proteinuria. However, we need to know that it has a low sensitivity to identify nephropathy. In other words, you can have patients with advanced kidney disease, but a proteinuria may not be as evident. So it doesn't correlate always with the GFR decline. A better, less used tool is urine microscopy. So it's useful even in making the diagnosis, and it's useful in assessing disease progression. I don't do that in the clinic, and I don't know if my colleagues from nephrology have ordered this for our Fabry patients. So the three basic findings are the vacuolated GL3 filled cells, which are called Maltese cross particles. Also, another type of cells, the distal tubular cells, which are called urinary mulberry cells, and podocyturia. A podocyturia considered to be a very good tool because it reflects continuous glomerular injury, and its quantification provides robust evidence of podocyte damage. Sorry. Okay. So if we summarize, this table is actually taken from the paper I told you about, and it summarizes the diagnostic tools to assess the kidney disease and Fabry disease. One of the easier tools are the systemic blood pressure we spoke about, the ultrasound findings, as we said, with the more prevalence of renal cysts, urine microscopy findings of hematuria and the cells in the urine, the hyperfiltration in the early stages, and the albuminuria, proteinuria, and the progressive decrease in the GFR as part of the glomerular manifestations. And also we can see tubular manifestations with evidence of distal RTA, isothenuria, and rarely Fanconi syndrome. We don't encounter this usually. evidence for podocyte involvement, and we spoke about that, the glomerular sclerosis, podocyturia, and proteinuria, and the biomarkers that we use, which are the GL3 and the lyso-GL3. Do we need kidney biopsy? And the answer, yes, sometimes we need it. And the situations where we need kidney biopsy, one, to assess the degree of the renal disease, to assess the degree of the damage, if we can really salvage and to guide us on treatment. So can we salvage this kidney by actually enzyme replacement therapy, especially in affected females? Kidney biopsy is very, very valuable. Also, in patients who have proteinuria or albuminuria, to see if they have GL3 deposits as well. Although this is, for me, is not a very valid reason. But the other valid reason, if a woman has no evidence of Fabry nephropathy, then if she has renal deposit, that will be an indication for the start of treatment. Kidney biopsy may be also very useful in atypical presentations and patients with non-specific nephropathies, as we would do all the time. The other indicator for kidney biopsy, indeed, when patients develop antibodies against the enzyme. Now, in enzyme replacement therapy for Fabry disease, especially with agalsidase beta, antibodies are major problems where patients can have rapidly increasing titer of antibodies. The fear of antibodies that they may neutralize the enzyme, so the enzyme will not be working and the patient will continue to progress in his disease. And to assess that, sometimes you will need to actually do kidney biopsy and see if the renal disease is progressing or not. What would you see in kidney biopsy? So you can see the vacuoles. This is the light microscopy. You see I don't know, can you see these vacuoles on your screens? In the podocytes, you will see them, and the glomerulus, you will see them, and the distal tubular cells, you will see them here, and the Henle lobes. And you can see the vacuoles very well. The vacuoles here are black under electron microscopy. This is a much larger image, and you can see them in the epithelial cells, in the mesangial cells, in the podocytes here, and the parietal epithelial cells. And this is just a larger magnification of these vacuoles. So these are characteristic, and you don't miss them in the renal biopsy. We finished diagnosis, reaching the last but not the least part. How do we manage the renal manifestations? A non-specific management, but can have a high role in delaying the involvement of the kidneys, actually the ACE inhibitors and the ARBs, kidney by optimizing the blood pressure and reducing the proteinuria and renal disease progression. There is fairly good evidence of the use of these two classes of medications at early stages of Fabry disease. There is some point I didn't mention in the slide. If there were questions about for patients with end-stage renal disease who require renal replacement therapy, if there are specific preferences in hemodialysis, and the answer is no. You will just treat them like any other patient with end-stage renal disease. When we come to kidney transplantation, also is similar. So the graft survival, patient survival are similar to those transplanted for other causes. However, if the patient has significant cardiovascular involvement, the long-term graft survival will be negatively influenced. And also there were case reports of transplanted kidneys that even developed the histological signs of recurrence of the disease. But there was no evidence for these patients that the long-term graft survival was affected. When we start enzyme replacement therapy, Fabry disease nephropathy, the usefulness or the benefit or the outcome of enzyme replacement therapy is really dependent at the timing of treatment initiation. So the kidney disease progression is better attenuated in patients who start the ERT at a younger age and have preserved kidney function at the baseline. And if you have the patient already at advanced level of tissue damage, enzyme replacement therapy may not improve at all the renal function. It may not even stabilize it. It's useful. And that's why we are going back to the level of the kidney involvement is very important if we are initiating enzyme replacement therapy for the renal disease. We also need to know that patients with similar levels of albuminuria may respond differently depending on the extent of kidney damage before the treatment. So even when you start patients on enzyme replacement therapy, their responses, as I said earlier, will be very variable. These are the general recommendations for enzyme replacement therapy initiation in Fabry patients. In males, it's straightforward. Nowadays, the latest guidelines, all male patients with a classic disease have to be started on enzyme replacement therapy as early as the age of 7 years. If you follow the guidelines along the decades, you would know that if you follow the guidelines along the decades, you would know that the guidelines, it changed rapidly. At the beginning, ERT was advised to be started at the age when albuminuria starts. Then it was advised to be started at the age of 16 years, regardless the albuminuria. Even in this patient, it was found that starting at age of 16 is already too late, and to protect the kidneys, especially the kidneys best, you need to start the ERT at the age of 7 years, and who knows if this will change or not. If the child is symptomatic, you may start the treatment even earlier. For females, the story is different because if the female is asymptomatic, you don't treat her because she may never get symptoms. But if she has evidence of major organ involvement, we need to start the treatment at any age. So in a female patients who are asymptomatic, ERT should be considered when there is evidence of renal injury, either through laboratory evidence of low GFR or persistently high albumin to creatinine ratio, or with histological evidence of the disease. Tamam. There is one last information when we speak about enzyme replacement therapy and Fabry disease nephropathy, that the actual dose of the enzyme matters. So this was found through different observations. I'll tell you about that, but it was shown through serial renal biopsies follow-up in male patients with a classic Fabry disease, that the elimination of GL3 deposits and podocytes and the reduction of the biomarker, which is plasma lyso-GL3, correlated with the cumulative effect of the offered enzyme dose. Now, to clarify it more, the two commonly used forms of agalsidase enzyme are agalsidase alpha and agalsidase beta. Now there is another ERT that was approved. But for agalsidase alpha, we use it at the dose of 0.2 milligram per kg per dose, where agalsidase beta, we use it at 1 milligram. It means that the dose of agalsidase beta is 5 times higher than the dose of agalsidase alpha. And it was shown that this higher dose by its own did actually result in a difference in the renal clearance of the GL3 deposits. Indeed, other organ involvement wasn't shown to be different between the two enzymes. As far as I know, they were as effective in different and multiple studies, but this is one of the main findings is about the renal response. So there are two studies here that talk about this as well. Study number one, they had patients on agalsidase beta, then the supply was interrupted, and then the supply was restored again. So they went back from agalsidase beta to agalsidase alpha to agalsidase beta. And they found that when they moved to agalsidase alpha, the GFR decline was faster, the lyso-Gl3 levels were higher, and when they went back to agalsidase beta, this was improved again. So they suggested that this may be due to the fact that agalsidase beta is already given at 5 times higher dose. This is another study that involved, this is a retrospective study as well, multicenter on 387 patients on ERT, and they showed that the reduction in plasma GL3 was more robust with agalsidase beta treatment, specifically with men and classic phenotype. However, in that study, during the follow-up period, not the follow-up period, it was a retrospective study, but they didn't see for the patients included in the study a remarkable difference in the decline in the GFR between the two groups. So when do we start and when do we stop enzyme replacement therapy is always a big deal for us and who work with enzymes for different diseases. And the consensus for Fabry disease, if the patient has evidence of end-stage renal disease, he should still continue on enzyme replacement therapy for the huge benefit on the other organ systems, including the heart and the brain. So a patient with renal disease shouldn't be withheld from ERT. However, if the patient have with the end-stage renal disease, he has an evidence of advanced heart failure, then it may be realistic to not to offer the treatment. And we made this decision for one patient who passed away, unfortunately, because of the disease progression. But again, we feel that with the advanced heart failure and end-stage renal disease, there is no other organ we are trying to salvage. How do we monitor the patients? The tools that we use in the clinic are the tools that are used by everyone. So we monitor the GFR of the patients and the albuminuria and proteinuria. And we do them annually in patients with low risk for progression of chronic kidney disease, every 6 months in moderate risk and every 3 months in high risk. I came to the end. I'm sorry for the very long presentation, but here are a few things that we need to keep in mind today. That Fabry disease, nephropathy still go unnoticed, can be missed, can be underdiagnosed. A high level of suspicion and knowledge of the disease is really useful for changing this scenario. Renal biopsy can be an important tool for the diagnosis and treatment decisions in Fabry disease. Enzyme replacement therapy is proven to slow the deterioration of the renal function, but we have to keep in mind that the response to enzyme replacement therapy is highly variable, and the decision is different or varies from patient to patient. And always early diagnosis and treatment are associated with better outcomes. Thank you for listening, and I'm open to hear any question from your side.